balancing. We talk about it in shoulder arthroplasty, but not in repairs. I think it's really important. So the SCR, I think, is a little bit like religion. It stokes a lot of emotion in people, and you have to believe in it or not. So hopefully I can get you my take on this. Allegedly this guy Voltaire came up with this, but Hawk taught me back in the day that if you wish to converse with me, you must first define your terms. And so that's what we're going to do real quick. We're talking about massive tears, greater than 5 centimeters of retraction. We're typically talking about the supraspinatus and infraspinatus without significant extension into the subscap or the teres. We're talking about fatty atrophy and infiltration on the grade 3 to 4 level. And so we're talking about irreparable tears. And if you look at the ideal patient for the SCR, they've failed non-operative management. These patients are people who have already had their therapies and they're still back. They have irreparable supraspinatus, infraspinatus. Ideally here, again, the ideal patient has full active range of motion, but their primary complaint is pain. Weakness can be kind of a secondary complaint as well, but pain is my main driver for this. If they have a repairable subscap, meaning like a 1 anchor, kind of 2 anchor, I think that's a great patient. But if you're getting into that retracted patient, subscap tear, maybe not. I think pseudoparesis and pseudoparalysis are something that Hawk kind of beat into my brain. If you look at the picture here on the right, the lady in A has pseudoparesis. Her pain is limited, her motion is limited, but probably secondary to pain. If you give her a lidocaine injection, it's probably going to come up. Whereas if you look at an exclusion of pseudoparalysis, the gentleman on the right has escape. He's lost balance. He can no longer bring that shoulder up. Arthritis is also an exclusion. Primary fixed proximal migration on X-ray is an exclusion. Irreparable subscaps and teres. Isolated external rotation lag. I think we throw these into the same bag as lower trap transfers. Most of my lower trap transfers, and maybe Jacob can expand on this later, don't really have much pain. It's a functional issue. They don't like not externally rotating. The SCR won't get you there, and I don't think many other things will. And then inability to follow post-op rehab.